Good afternoon. I am Wissam El-Bassiouni. I am a training and learning manager with Biotech Healthcare Company. Thank you very much to join us today with our first webinar. We try to do our best to transfer the knowledge we have to our surgeons and the KOL worldwide. We just need to utilize this time of COVID-19 to introduce what we have from the knowledge from our speakers and KOL. Today, we have our first webinar in orthopedic business. The subtopic of the webinar will be introduction of orthopedic oncology and the management of bone and soft tissue sarcomas. We just need to wait some time, like 1 minute or 2 minutes, so other attendees can join us. I will utilize this 2 minutes to talking about Biotech Healthcare. Biotech Healthcare is a manufacturing company. We have our manufacturing platform in Ireland. We specialize in the hyaluronic acid production. We have 3 verticals: ophthalmology and dermatology, and our big line for the orthopedic business. We started our business 25 years, since 25 years, and we are now one of the big market leaders for this business, and we hope to launch our products in new countries worldwide. The webinar will start with 30 seconds. Sure, it is a pleasure to introduce my speaker today, Dr. Ahmad Al-Absi. Dr. Ahmad Al-Absi is an orthopedic consultant, and also he is a head of sarcoma units in King Fahd Specialized Hospital. Sure, I'm lucky to work with Dr. Ahmad since now 9 years, and I know his talents. I know how much he's care about the knowledge, and I know his Dr. Ahmad experience in the oncology business. I think so more than now 10 years, and I'm lucky to attend with him a lot of surgeries when I was my ex-company. I will let Dr. Ahmad now start his presentation, and on the right side you have a part of comments. If you have any comments, any question, any inquiry, we will handle it by the end of the presentation. So please write your comments in the comments field, and I will ask this question by the end of presentation. Dr. Ahmad, you are welcome. Please start. Dr. Ahmad.
Yes, thank you, Sam, for the nice introduction. And it's 4 o'clock right now, so good afternoon, everybody. Again, I'm Dr. Ahmad Al-Absi. I'm a consultant orthopedic surgeon, and I'm specialized in orthopedic oncology. As well, I've been doing orthopedic oncology for the last now 13 years with Sam, almost 13 years since qualification. So today I'm going to talk to you about the orthopedic oncology service, and we'll discuss also what we will do in orthopedic surgery in terms of Sam.
Yes, Dr. Ahmad, I'm here.
I am Sam. Okay.
Okay.
So we'll talk about the orthopedic oncology.
Yeah, please share the presentation. The presentation not shared.
Is it clear now?
It is clear now.
Yes, so we'll talk today about the orthopedic oncology and how we approach bone and soft tissue sarcomas. And we're going to be a little bit toward more the basics, but I'll try to give you as well part of the advanced knowledge or the advanced surgical techniques that we do in orthopedics. I have nothing to disclose. What we will discuss today, we'll discuss the orthopedic oncology service and what do we mean by orthopedic oncology practice. Is it like regular orthopedic surgery, or people has to be specialized in doing such studies? We'll also give you some basics about the sarcoma, what do we mean by sarcoma, and how do we approach these patients. Then we'll talk about the approach to bone and soft tissue tumors and how do we stage them, how do we investigate them, how do we treat them as well. Most of the surgeries that we do in orthopedic surgery, it's basically they go under the title of limb salvage surgery. So in the 1970s, people used to do amputation for all patients with bone and soft tissue sarcomas. But then later on, the more improvement in precise imaging techniques, as well as the chemo and radiotherapy, we started to learn about the limb salvage surgery. So people get more training, and the limb salvage surgery right now is the standard of care for treatment of all bone and soft tissue sarcomas. Now, moving a step forward toward joint salvage surgery is the current state of art right now, where we don't usually save the limb alone, but we also save the joint, so the patient can enjoy better life and he enjoy having his hip or knee joint or elbow joint. We'll talk a little bit about also pathological fracture, which is one of the most serious problems that occurs in patients who have a bone sarcomas, either before the diagnosis or before we reach the diagnosis, or within the course of their treatment, they get the fracture. So we'll talk a bit about it, how do we treat it and how do we manage it. Also, we'll touch base on pediatric bone sarcomas. As you know, pediatric age group is a very challenging age group. They have a growth plate is still open. So treating these patients will also be a bit difficult because you have to retain the growth potential, and you might end up with limb length discrepancy if you treat these patients and taking out the knee joint or the hip joint. OOPS surgery is one of the common terminology that I would really like to introduce you to what do we mean by OOPS surgery, how do we manage these patients. Again, we'll talk a little bit about the role of amputation in orthopedic oncology. This is one of the very important aspect to be discussed as well, because people think that if we do amputation, it's a failure of treatment. Rather, no, it's not a failure of treatment. It's one of the options of treatment in certain cases, and we'll talk about this as well. So in general, orthopedic oncology service is a very unique service. We only have 4 or 5 orthopedic oncology or sarcoma centers here in Saudi Arabia, where we deal with bone and soft tissue lumps and bumps. And the way we treat these patients is within a multidisciplinary team approach. So my role as a surgeon is just part of being part of this team, and I definitely cannot function alone. I need the help from the medical oncologist, radiation oncologist, as well as the radiologist, intervention radiologist. We do have also a bone and soft tissue pathologist. It's very important as well to have medical oncologists and radiation oncologists who specialize or had an interest in bone and soft tissue sarcomas, because these are rare tumors. So you really need somebody who had a good experience in these. The importance of having a pathologist in a bone and soft tissue pathology is very, very important, because again, we have more than thousands of cases of thousands of types of soft tissue sarcoma, while bone sarcoma is around 20 or 30, and they're all rare. That's why you need to have somebody who had a good knowledge in these cases. We have also sarcoma coordinator and clinic nurse coordinator, psychologist, and social worker as well. So this is our sarcoma team or multidisciplinary tumor board team. For a sarcoma surgeon to practice in this field, he has to have a fellowship training in sarcoma surgery. These are not the cases of anybody can do the surgery like a surgical general surgeon or a general orthopedic surgeon. The sarcoma surgeon has to have an excellent experience in bone and soft tissue tumors. Actually, the most important part of the treatment is the decision to treat, and then comes the surgery, and then further reconstruction. So these all training, you only get it in a certain centers, which you get a fellowship for a year or 2 years, and then you get this experience. And then when you come back to treat these patients, you have to work in a tertiary referral centers. And again, we do have a very few centers in Saudi Arabia. Again, we talked about the multidisciplinary team approach. This is our essentially organizational framework. All our patients, they go to multidisciplinary tumor board or they go to the sarcoma board for treatment. And as you all know, that the complexity of management of bone and soft tissue malignancies, it does necessitate an organized structural approach involving many disciplines. And that definitely will lead for a better patient care and more satisfying experience, even for us as surgeons or medical professionals, because you discuss the cases, you review all the investigations together with the involved specialties, and at that time we concur with the diagnosis. Well, quite often we have cases where we have diagnosis, and when we come to the sarcoma board, we review the X-rays and we review the pathology, and you find that there is some kind of discrepancy between the radiological and pathological features. At that point, we have to discuss it again, revisit the diagnosis again. So the diagnosis is part of the responsibilities of the tumor board as well. If we concur with the diagnosis, then we put the management plan all at once. And then the process starts immediately. So we start to treat these patients immediately, and patients get access to care immediately. All preparations for the patient to come to the clinic and then get admitted, get treatment, everything. So what cases will show up in our orthopedic practice usually? Usually we see metastatic bone disease. Most of the cases of metastatic bone disease, they come to us. Benign soft tissue lesions, benign bone lesions, metastatic malignant soft tissue tumors or sarcomas, malignant bone tumors or sarcomas. And quite often we receive also cases of failed arthroplasty surgeries for revision with the tumor prosthetic replacement, especially as you know now with the increased prevalence of osteoporosis, especially in females and in older population, patients usually get a low supracondylar fracture, periprosthetic supracondylar fractures of the distal femur, where probably this treatment is just to revise it completely for distal femoral replacement or proximal tibia replacement, and then you get over with it, patient gets to move quickly. So, but most of the cases that we see, honestly, is malignant soft tissue and bone tumors, because most of the benign soft tissue and benign bone lesions are usually dealt with in the other hospitals. So back to basics, what do we mean by sarcoma? To know what do we mean by sarcoma, we should know that we should recall from embryology that the area is composed of 3 lines. Is the ectoderm, mesoderm, as well as the endoderm. The mesoderm is the origin of the sarcoma. So by sarcoma, we mean and this mesenchyme into bone and muscles and other soft tissue components, while the endoderm will develop into the lining or inner lining of an organs. So when we talk about cancer, we mean by cancer, it's either carcinoma or sarcoma. Carcinoma, we mean by cancer, carcinoma is a cancer of epithelial tissues or glandular tissues, while sarcoma is a cancer or the disease of a connective tissue with a mesenchymal origin. A classical sarcoma that we see is a broad sarcoma and soft tissue sarcoma. In the images on the right side, this is an osteosarcoma of the right femur, and the left side, this is a soft tissue sarcoma, and it has, you can see it's a huge sarcoma. This patient gets into a stage where his tumor is really huge before he gets back to me or he comes to me for investigation, which turns out to be a very aggressive high-grade synovial sarcoma. While what are the cancers that usually come to the bone and we ended up dealing with them? It's the metastatic bone disease. Commonest is the prostate in males and breast in females. We see a lot of kidney tumors, thyroid tumors, and lung tumors, as well as these metastasizing to bone. As you all know, the incidence of cancer is about 500 cases or 470 cases per 100,000, while bone sarcoma, for every 100,000 case, we get for every 100,000 population, we get 1 case of bone sarcoma. Soft tissue sarcomas are usually 3 times much more common than bone sarcomas. So if you make your calculations, we know that sarcoma accounts for less than 1% of all of these cancers. That's why you really need people who are subspecialized. You only do these kind of tumors to get more experience and to increase their learning curve for better results and outcomes for our patients. While metastatic bone disease, the annual incidence of metastatic bone disease is more than 2 million cases. So if you look back here, probably the annual incidence of these cancers is extremely low compared to carcinoma. That's why, again, we need more expertise. We know that 80 to 85% of patients with visceral carcinoma has evidence of bone metastasis at biopsy. So it's estimated that we get around 2 million cases of new metastatic bone disease per year. And the ratio of primary to metastatic, for every primary bone tumor, we get 155 of metastatic bone disease. Again, we talked about the bone sarcoma. By sarcoma, we mean either malignant bone disease or soft tissue disease. But we're lucky that benign lesions are much more common than malignant lesions. They're 20 times much more common than malignant lesions. But in practice, again, we deal more with malignant diseases than benign lesions. Quite often, these lesions, the benign lesions, are dealt with the general orthopedic surgeons. So our practice is really very busy dealing with these sarcoma cases. I can tell you in my center, we received around 300 to 350 cases of referrals of a sarcoma from the East province of Saudi Arabia, of a targeted population around 7 to 8 million cases, and we operate around 120 to 140 cases per year as well. Again, soft tissue sarcomas, there are thousands of them. The famous Nzinga-Rice classification or book, a textbook of pathology, they classify them into thousands of tumors. And every 4 to 5 years, we get this WHO classification, new classification from WHO. And I think the newer one is coming next year. While bone sarcomas, we only have 25 to 30 diseases. But luckily, soft tissue sarcomas, they're generally grouped together according to the cellular morphology, immunohistochemistry, and cell markers, molecular studies, and recently the microarray expression analysis and next generation sequences. But if you look back to our basic, when we were trained, what do we mean by bone sarcomas and how do we classify them? We classify them either to the origin, the cellular origin, which is either bone origin, cartilaginous, fiber, round cells, or giant cells. The osseous lesions, you could have a benign osteoma, osteoid osteoma, while the malignant osseous bone tumor is an osteosarcoma with all the categories of subclassification. While cartilage tumors, we can get a benign cartilage tumor, or we can have also malignant cartilage tumors, which we call chondrosarcoma. One of the most difficult tumors to understand, as well as difficult to treat, to know the cellular origin, is the round blue cell tumors, which we call the Ewing sarcoma or peanut family of tumors. And with this also round blue cell tumors comes also lymphoma, multiple myeloma. Again, soft tissue sarcomas, there are thousands of them, but back again, if you look at the early classification of lesions, again, they look at the cellular origin, whether it's a fibrous, fibrohistiocytic, lymphomatous, smooth muscles, skeletal muscles, vascular, synovial. So these are all, if you go, this is a very old classification. And again, the WHO classification 2016, this is the latest, and we're still coming with the 2020 or 2021, we will have the newer classification. The problem always with soft tissue sarcomas that they usually present as an innocent mass. What do we mean by innocent mass? It's usually a painless mass, a mass that grows over time, but never been painful. It's only painful when it compresses the soft tissues or compresses the bursa or nerves. So that's why most of the time in this part of the world, patients come to me with a really huge size of soft tissue sarcomas. I can tell you one of the cases that I've done in my practice, a tumor that reaches a size of more than 65 kilograms. It's probably the largest ever soft tissue sarcoma, soft tissue tumor that was ever reported in the literature. I will report this case actually soon. While bone sarcomas, they come with pain. That's why patients usually come much earlier than patients with the soft tissue sarcoma. And bone sarcomas usually occurs in adolescents and young adults, usually in the first and second decade of life, while soft tissue sarcomas occur usually in the age of 50s and 60s. It's a disease of middle age to an elderly population. But again, in oncology, you get many surprises, and you have many overlap and so many surprises. Some soft tissue tumors in pediatric age group, I have operated like 3 months ago or 4 months ago on a newborn who had an infantile fibrosarcoma, huge infantile fibrosarcoma of the posterior thigh. And he was just born. And occasionally you get bone tumors which were diagnosed in childhood and infants even. I've also diagnosed a patient who had a metastatic Ewing sarcoma of the band diaphyseal, of his band diaphyseal femur in 1 year old. So you get so many overlaps and tons of surprises in our practice. What about radiological evaluation? I can tell you if you attended the lecture about how to evaluate a patient, an X-rays of a patient with a bone tumor, I can tell you that you probably will be able to reach the diagnosis, but by having a systematic way of reading an X-rays. If you look at this X-rays, there is an abnormal lesion or an abnormal growth, we call it in oncology, permeative pattern of bone destruction in the proximal femur with an obvious soft tissue mass, and that lesion is forming bone or laying bone. So that definitely is a malignant bone forming lesion. So X-rays is our working horse in the diagnosis. Most of the time, we teach the residents that if you do a proper X-rays and you interpret the X-rays properly, you most likely you will reach the diagnosis. While soft tissue tumors, the initial scan, we do ultrasound and sometimes we do CT scan if there is a tumor in the pelvis. And the most important diagnostic modality is having an MRI of the involved extremity with contrast. That will definitely tell you what kind of lesion is this. Where do these tumors metastasize? They commonly go to the lung, and this is the image shows you these lung metastases from a sarcoma, and they're typically, we call them cannonball metastases. But sometimes these tumors also they go to the lymph nodes if you are subtypes like synovial sarcoma, rhabdomyosarcoma, epithelioid sarcoma. That's why we always include PET scan in the diagnostic armamentarium of these patients, because we're looking at lymph nodes, and lymph node involvement will definitely change the modality of treatment. I'll give you this example. If you look at this chest X-ray, this patient, he's a 21 years old male patient. He presented to the emergency room in our hospital having cough, hemoptysis, and shortness of breath. When they did an X-rays, they called the thoracic surgeon. They looked at the X-rays. They found this is metastatic tumor from wherever. So they examined him. The patient reported that he had a mass in his right thigh, and when we were called within an urgent MRI, we found this mass in his right thigh that he never complained of, that he saw the mass but never having any pain or anything. Now we took a biopsy kind of a sarcoma, we call it alveolar cell clear, alveolar soft tissue bar sarcoma, and now it's metastasizing everywhere. Metastasis to the liver, metastasis to the lung, and metastasis to the lymph nodes. And unfortunately, the guy died after 6 months of beginning his palliative chemotherapy. Now, how do we stage these tumors? By the time the patient comes to you with the X-rays, you know that this is tumor, patient goes in protocol immediately. So if you have a bone tumor, we do local cross-sectional imaging using an MRI. We always combine the MRI with the CT scan as well in the pelvic tumors. We do CT scan of the chest as well, and bone scan. And if you have a diagnosis of Ewing sarcoma, we always include bone marrow aspiration, bilateral bone marrow trephine aspirates, and sometimes we include as well PET scan. For soft tissue sarcomas, we do local cross-sectional imaging, as I said, by MRI, and we also order CT scan of the chest, because the commonest metastasis, as we said, this is a lung metastasis. But some cases we order also CT scan abdomen and pelvis, and these are the cases where we expect these tumors to go to the pelvic and retroperitoneal areas, and especially in tumors of a myxoid origin like myxoid liposarcoma. Now, after you do your staging, you do biopsy. Biopsy will give you the definitive diagnosis, and again, it has to be the same surgeon who will operate, and we have to have a strict adherence to sarcoma tumor protocol or biopsy guidelines, because poor biopsy may render limb salvage impossible, and we'll talk about this also. And most commonly, we do non-invasive biopsy using an image guided, but if we fail, we do open biopsy. And then we come up with the staging system. The very famous staging system is the Mankin staging system, and you all know that low-grade tumors are stage 1 and high-grade tumors are stage 2, while metastatic is stage 3. If you have a low-grade tumor within the compartments called low-grade intracompartmental, 1A, by 1P is low-grade extracompartmental. So B is for extracompartmental disease and A for intracompartmental disease. The commonest presentation of these bone and soft tissue bone tumors is usually high-grade extracompartmental, while the soft tissue tumors or soft tissue sarcomas are classified according to the AGCC system, which is the TNM classification. Then what is the principles of management? After we reach an accurate histological classification, we discuss the cases in the multidisciplinary tumor board, what is the aim of our treatment? The most important goal of treatment is the oncological outcome. So we need to get a negative margin surgery, wide local resection, important to avoid local recurrence. And then we look at the limb and organ function to reduce the morbidity and definitely will improve the survival. So this is our surgeon's perspective. We look at the local control from oncological point of view, and then we look at the limb function. And then we look at the morbidity or the cosmetic or the way the limb or the organ looks like to the patient. But that's definitely different from the patient's perspectives. What the patient looks at is usually he looks at the cosmesis, looks how the wound looks like, and how's the function of the leg. And sometimes he cares about the oncological outcome. But the most important thing is the oncological outcome. And that treatment has to be indefinitely in specialized centers. This is the center where I was trained in Canada, and this is the center where I am working right now in Saudi Arabia. People have to have an adequate experience in treating these bone and soft tissue tumors, and you have to have an adequate funding to support the treatment. It's a very costly treatment, chemotherapy, radiotherapy, and also the implants are very costly. So you have to have an available resources to be able to treat these patients. What are the principles of treatment? In general, bone sarcomas are treated by surgery and chemotherapy, plus minus chemotherapy. The standard treatment of osteosarcoma and Ewing sarcoma, which are the two most commonest bone sarcomas that we see, is a sandwich protocol where we give the patient neoadjuvant chemotherapy in the beginning, and then they come for the surgery, which is wide local resection, and after the surgery, they go back into adjuvant chemotherapy. Now, the rule of radiotherapy in bone sarcomas, yes, there is a rule of radiotherapy, especially in Ewing sarcoma. Sometimes we use radiotherapy as the definitive local control modality in Ewing sarcoma, or we can add this radiotherapy as an adjuvant to the treatment, either in a preoperative setting or postoperative setting. While the soft tissue sarcoma, we treat these patients mostly by wide local resection of the tumor plus radiation, either in a preoperative or postoperative. Now, there is always a debate whether you use a preoperative or a postoperative treatment, and there is a very famous randomized studies as well as meta-analysis of which one to use, either preoperative or postoperative. And this is, if you look at the University of Toronto, they have published a very nice article comparing what is the oncological outcome as well as the wound complications in pre and post, and all the results in keeping with using preoperative radiation therapy, but on the expense of wound complications. But we do follow the NCCN guidelines. If you look at the NCCN guidelines, it tells you either you go for surgery followed up by radiation, or you give the patient radiation therapy and followed up by surgery. But the reason why they put these two options, it's just to give the surgeons or to give the tumor board also the freedom to decide which patient goes on which arm. Like for myself, I always give the patients preoperative radiotherapy followed by surgery, unless if I think that there is no much soft tissue envelope on top of the tumor, and there's the flaps that I will be creating during surgery will be very thin, and to give them preoperative radiotherapy will definitely increase the wound complication and ended up with major problems. So I opted to do always in these cases surgery followed up by followed up by radiotherapy. Now, the role of chemotherapy is very controversial. Some centers, they give patients preoperative chemotherapy. Some patients, they give them postoperative chemotherapy. In our center, we do not usually, or we do not routinely give these patients chemotherapy, because we base our studies, we base our decision based on the studies. If you look at this study, it was published in the Journal of Cancer 2008. They talk about the adjuvant chemotherapy for localized resectable soft tissue sarcoma. It was published from McMaster University in Canada, and that study also showed the marginal benefit with respect to local recurrence and distal metastasis and overall recurrence. And if you go more deep in this study, we know that the number needed to treat is 1 out of 16. So subjecting 16 patients to chemotherapy to get the benefit for one only, which is still marginal, is a bit debatable. That's why we don't usually give. But for some tumors like synovial sarcoma and myxoid liposarcoma, this is part of our standard of care to give them chemotherapy. And then patients come to surgery. Again, we talked about that amputation was historically the standard management, the standard treatment in 1970s. But right now, 95% of patients can be salvaged by limb salvage surgery. Now, we have a recent focus on functional outcomes, and that's what we'll talk about joint salvage surgery. Survival, it's a crude estimate or a rough estimate. Bone cancers, you usually have 60 to 70% of 5-year survival, while soft tissue tumors, their prognosis is a little bit worse. It's a 50% in 5 years. There are multiple survival nomograms that sometimes we follow. The Memorial Sloan Kettering survival nomogram is a very nice nomogram to follow. And recently, if you're a guy who loves technology, you can download the application of PERSARC mobile application. This is from the University of Leiden, and they put for you every single type of soft tissue sarcoma together with the pre-op treatment, the depth and the location and the age of the patient, and it gives you a rough estimate so you can communicate it with your patient. But basically, a sarcoma is a surgical disease. So we depend heavily on the surgery to achieve a better oncological outcome. And the type of surgery we know, this is the oncological resection. It's either intralesional or intracapsular or marginal resection or wide local resection or radical resection. The one we use right now for sarcoma surgery is wide local resection, and we do not use marginal resection or intracapsular resection. Again, there is a paradigm shift, this whole paradigm shift from amputation to limb salvage surgery, because we have a precise imaging techniques, chemo and radiotherapy, and we have more surgeons are trained in orthopedic oncology. Again, we have a step forward ahead of limb salvage surgery, which we call a joint salvage surgery. So limb salvage surgery is any procedure that designs to accomplish removal of a malignant bone tumor in acceptable oncological, functional, and cosmetic results. So the top priority is oncological outcome, and then we care about the function, and third, we care about the way this limb looks like. It has all replaced amputation as its standard of treatment. What do we get from limb salvage? We get an excellent tumor resection, and if you look at the literature as well, you might argue what is the advantage of limbs, what is the, if you compare limb salvage to amputation, what is the status of the margins and what is the local recurrence? I can tell you a well-planned limb salvage surgery can gives you a lower local recurrence rate of similar to amputation. So why do you have to amputate the limb if you can do the limb salvage surgery with the same recurrence rate? And definitely patients will enjoy relief of pain, we have an improved quality of life, and definitely they will have an intact body image that limb salvage can offer, even if they may not survive long. But there are still barriers to limb salvage, like poorly placed biopsy incision. We have seen so many cases where the incisions are put transversely and contamination. There's a lot of hematoma, so you cannot salvage the limb. They contaminated the vascular or the neurovascular bundle. That makes it really difficult for us to do the limb salvage surgery. Major vascular involvement, encasement of a motor nerve, pathological fracture of the involved bone. These are not absolute. There is nothing called absolute indication for amputation or a barrier to limb salvage. But if you think there is a rule which I always look at, which call it the 3-strike rule. So you have the bone, soft tissue vessels, and the soft tissue envelope around the tumor. So 3 of them involved, then you can decide, or you can tell the patient probably amputation will offer you better oncological outcome and function compared to amputation, compared to limb salvage. So limb salvage, we care about tumor resection first, and then we care about reconstruction. The tumor resection, you do the bone and soft tissue tumor resection, you care about the oncological outcome, and then you care about the reconstruction. For reconstruction, we reconstruct the bone defects by many methods. Autogenous bone graft, tumor prosthesis, which is the commonest way we reconstruct these defects, and sometimes we use segmental allografts, and we use an allograft with the bone, we call it allograft composites, and sometimes we also use biological methods, and there are so many other techniques. If you look at the literature is full of techniques that tells you how to do these reconstructions. I'll give you, this is an example. This is one of the commonest reconstruction techniques that we do, is a modular tumor prosthesis. It's a 37-year male patient presented with a biopsy-proven high-grade chondrosarcoma of the distal humerus with pathological fracture. As you see, also he was biopsied outside, and then he was referred to my clinic for further evaluation. The tumor, which is around 16 centimeter with a bit of bone edema on top of it in the intramedullary area also. So what we did anterior approach. We resected the tumor completely. If you look here, we also dissected all the neurovascular bundle, the radial nerve, median nerve, ulnar nerve down, and this is all the neurovascular bundle. Tumor was resected, and this is the modular endoprosthetic tumor replacement. We replaced this by distal humerus replacement with an elbow joint replacement as well. This is his AP and post-operative. And this is the X-rays and this function well, and flow reflection and extension. So these prostheses, we call it modular because it gives you an intraoperative flexibility during surgery. When lengthen or shorten, when I use what kind of a stem, what kind of coating of the stem. So this is the commonest that what we use. Something which is offline, I'm sure if some of the audience are orthopedic oncologists, I'm sure they have some cases like this. This is a pelvic tumor. This is a 16 years old female patient that we have recently treated 4 weeks ago. She presented to us with, referred from another country. She had this lesion here in the iliac wing that turned out to be an Ewing sarcoma. And she took a standard chemotherapy and she came for local control. We did the pulmonary resection, so we dislocate the sacroiliac joint from here, and we did the supraacetabular osteotomy through the sciatic notch right there. So we took the tumor out, and we did this kind of reconstruction, and we put two multi-axial screws here in the sacrum. If you look here in the sacrum, and also these another two multi-axial screws in the one in the anterior column, one in the posterior column. We connect these by spinal rods, and we put a bone cement around it. We close the one. She's almost now 4 weeks post-surgery. She's able to walk independently, and she's enjoying pain-free movement as well. So this is kind of an offline kind of management. It's not the standard, but this is another technique that we adopted for such cases. While soft tissue resection only needs soft tissue reconstruction. So this is another guy who was a 70 years old male patient. He presented with the mass in the right shoulder. I don't know if it looks like the right shoulder. This is his arm and this is his chest here. And somebody did the biopsy right there in the transverse incision, and the diagnosis was dedifferentiated liposarcoma, and he was non-metastatic. And he came to my clinic a year ago, and we did this kind of resection. We resected a huge amount of the soft tissues around the shoulder, and we reconstructed his clavicle. This is his clavicle here. We tagged it down to the acromion process by anatomic repair, and the defect was closed by our plastic surgeon with latissimus dorsiflap. So the soft tissue resection, soft tissue tumor resection, they need a soft tissue reconstruction. You have to have a reconstructive plastic surgeon who helps you in these cases. What about pediatric bone sarcomas? They're uncommon disease. The commonest, as we said, osteosarcoma and Ewing sarcoma. They usually occur around the knee joint. Limb length discrepancy is a challenging problem to us, which will lead eventually to destruction of the whatever growth plate, and that will eventually lead to eventual leg length discrepancy. Again, we have very good reconstruction techniques, and we use prosthetic replacement, but as you all know, because we have a still remaining growth potential, so we use an expandable prosthesis. Protection-plasty is, I know it's a green practice in many countries, but unfortunately, I have offered 4 or 5 patients of mine, and I showed them how rotation-plasty works and showed them pictures of rotation-plasty. None of the families, they accepted rotation-plasty as a treatment, and I still doubt if rotation-plasty is ever is being done in this part of the world, because people do not accept it at all. Biological reconstruction, we always like to go for biological reconstruction because this will definitely last longer than prosthetic replacement in younger age group. But again, still amputation in a very young patient. Like if you look at the COGO protocols, the Children Oncology Group protocols, it tells you clearly that patients below 3 years of age, we probably would like to do amputation compared to limb salvage surgery, because by the time they reach an adulthood, they will need tens of surgeries and the functional outcome is not proper. But if you do amputation early on, these patients, they can cope up with amputation fairly better than limb salvage. This is again a 10 years old female patient presented with a chronic pain in the arm. If you look here in this image here, there is a soft tissue mass there, and there is a periosteal reaction, and there is also here Codman triangles within an MRI. The MRI showed a tumor in the humerus as well as a big soft tissue mass. We took a biopsy, it showed an Ewing sarcoma, and she took a chemotherapy. She had an excellent response to radiotherapy. She came for local control. Again, within an anterior approach, we took the tumor out completely, and we used a humerus and fixed pipe plates. Tumor was resected. And if you look at the x-rays here, this is the post-operative x-rays. I know there is a mismatch between the allografts, but you know this is a young female, so it's very difficult to get a size-matched allograft. So we fixed it. And if you look here also, there is a marked or accidental collaboration between the allograft and the patient hospital proximity. We had a little bit of difficulties getting this distal osteotomy to heal, but eventually it heals with more grafting and further change of plating down there here. While expandable prosthesis, we use expandable prosthesis quite often in these patients, especially in tumors around the knee. This is a 9-year-old male patient presented in the emergency room with a pathological fracture of his distal femur. And if you look here, there is definitely a lesion in the distal femur, and that lesion is aggressive looking. It looks to me as a potentially malignant tumor. This is his x-rays as well. It looks like this tumor invading, going just above the growth plate. Was a biopsy proof. Osteosarcoma, was non-metastatic. He was started in chemotherapy and came for local control. This is his images, intraoperative images. The tumor was resected, and this is the expandable tumor prosthesis. It looks like exactly like a proper distal femur. I'll show you the differences. The difference is that stem, sorry, did not show the stem here, is a smooth polished stem. So it allows for growth of the proximal tibia here. This is one. And second thing, there is a motor inside this prosthesis that allows you also to grow or to lengthen this patient. And this is the motor here. So this image, it was done post-operatively. You can see the clips over there here. And this is the receiver film. And this image was done just a few days ago, 3 days ago, when he presented to my clinic. He was almost a year post-surgery. And you can see the difference, the space between this here and here, as well as compared to this space. And this is in the AP. The prosthesis, we are growing or we lengthening the prosthesis, and this is the motor inside. So that will compensate for the loss of the distal femoral growth plate, while the proximal tibial plate is growth plate still growing. And this is the way how we lengthen these patients. This is the device, this is electrical transducer, and the skin and the transmitter here, and we put it over the receiver film, which was buried in the subcutaneous tissue in the extremity, and we linked in these patients. And this is their function post-operatively, a full extension and almost full flexion as well. However, we still do amputations in very rare cases, but it's an option of treatment, and we always explain it to the patients that this is not a failure of treatment. And again, if you have a fungating tumor, this is one of the commonest indications. If you have fungating tumors or you have a massive soft tissue contamination. I'll give you this case example that I've seen a year and a half ago. She's an 8-year-old female patient. She had a proximal tibia osteosarcoma. She was non-metastatic at presentation, but the family refused treatment because of some kind of spiritual and cultural beliefs, and they went ahead to treat her by some herbal medicines. This is the x-rays. You can easily see there is a lesion in the proximal tibia that's forming bone. So this is a malignant lesion that forming bone, which is an osteosarcoma. This is her MRI. I have to say the lesion is quite big here in the tibia, but The patient unfortunately did not get to our treatment, and they refused. So they went to treat to some kind of herbal medicine and things like this. And 3 months later, she came back to us, unfortunately, with this picture. Look at the X-rays here. It's a massive blowout of this tumor. This is her lateral X-rays. Look at the tumor right there. It's a fungating tumor, a huge tumor here in this area. Patient looks cachectic, and she's malnourished, and she's in extremely very bad condition. So I don't think anybody can do anything apart from high above knee amputation for this patient. And unfortunately, she got the metastasis. She's metastatic for now, and she's in chemotherapy. Now, this is one of the interesting part of orthopedic oncology, is how to save the joints. Now, we talked about limb salvage surgery, what are the principles of limb salvage surgery, but this is a step forward from limb salvage surgery, which we call it joint salvage surgery. What do we mean by this? Trying to save the joint, utilizing a custom-made prosthesis or a kind of biological reconstruction, but you still keep the joint, because this is very important for the patient's recovery and eventual ambulation as well. Again, it's a step ahead of limb salvage surgery. It incorporates modern technology and precise imaging techniques with 3D printing implants, and we also use patient-specific implants. This is one of the cases that we done 3 weeks ago, 20 years old female patient. She had a biopsy proving Ewing sarcoma of the band epiphyseal femur. She was started in a standard Ewing sarcoma protocol, but unfortunately she did not respond to chemotherapy, so we have to give her concomitant radiotherapy in the middle of her chemotherapy. She had a marvelous response. If you look at the X-rays here, you could easily see that there is a lesion in the mid-diaphysis with evidence of soft tissue calcifications, as well as this lesion is here in the lateral. And this is her MRI. The MRI showed you the tumor in the intramedullary area, as well as a big soft tissue mass. And that's the tumor again in the sagittal images. Again, we talked about it. It's Ewing sarcoma. So they presented to me after she finishes her chemo radiotherapy for the surgery. We planned a wide local resection, and we thought about various reconstruction techniques, and I chose intercalary prosthesis, which we call a joint salvage prosthesis. And for this to know, we only have the original specimen was 26 centimeters. So we draw this with using special software with the help of the company, of course. We found that the distal part of the femur, we only have 5.5 centimeter, which is not enough to host or to anchor any stem in there. And here we only have proximal femur, we have 7 centimeters. It's also difficult to put any stem over there. So we did our own drawings, and we would help also the CT scan, a thin cut CT scan. The company helped us to manufacture this kind of patient-specific implant with the same exact anatomy of the distal femur, as well as this same exact anatomy of the proximal femur, with also a locking screw that goes inside the neck with a special TCB coating or tricalcium phosphate coating, as well as the trabecular metal in the outside as inside in the plates here. We always use these screws, cross screws here, for additional primary stability till the bone integration takes place in the prosthesis. So this is the tumor was resected here, and the prosthesis was put, and this is the original. This is the drawing, the patient, the prosthesis that will go inside the patient. It exactly looks the same like our drawings, and this is the one that goes in the proximal femur. If you look at the X-rays, this is the X-rays, this is the distal femur, the remaining distal femur, and that's the prosthesis, and these are the screws that I talked about, which gives you an initial stability before the bone healing occurs. And again, this is the proximal stem, and this is the screw inside the neck. And now the patient's almost 3 weeks. She's okay. She's walking well without any problems, and still waiting for bone to heal. Now, very important also aspect is the pathological fracture. What will happen if the patient comes to you with a pathological fracture? Is it a contraindication for limb salvage surgery? We said at the beginning, it's not a contraindication, but you really have to be careful how to treat these pathological fractures. And these bone sarcomas can still be salvaged, and we treat these patients by chemotherapy. It definitely will make the difference, but you have to have a well-planned surgery to reduce the risk of recurrence. You know, if you do, if you have an osteosarcoma that fractured, the venous sinusoids will distribute all these sarcoma cells within the soft tissues. So you have to immobilize the extremity before you give the patient chemotherapy. To immobilize the extremity, you have to span the fracture by whatever, by casting or external fixator, as well as you have to span the tumor. And that's very important. If you're using an external fixator, the principle is not to span the fracture alone, but you have to span the tumor, which means to be away from the tumor. You start chemotherapy, and then you have to plan limb salvage surgery. And if you look at the literature, and what does the pathological fracture affect the prognosis of osteosarcoma of the extremity or not? They always tell you this is not an absolute indication for amputation, but definitely it's associated with decreased overall survival and increase in the local recurrence as well. So I'll give you this example, which is really very interesting. He's a 23 years old male patient, had a chronic hip pain, and the diagnosis was Ewing sarcoma. He was non-metastatic. At the night before he goes to the chemotherapy, his first cycle of his chemotherapy, he had a pathological fracture. So he came to the emergency room. They called me, this is your patient, please come assist him. So I looked at the x-rays. He had an obvious subtrochanteric fracture here in the place of Ewing sarcoma is here. So we opted to treat this patient by external fixator. So we put a transacetabular external fixator, and you all know that this is a really tricky kind of supraacetabular fixation to put, especially if you put it from the lateral side. And we span the whole fracture, we span the whole tumor, and we reduce the fracture to obtain an optimum length here. You look at the fracture, this is post-operative X-ray after we apply the external fixator, showed an excellent alignment. And this is after the patient finishes his chemotherapy. You can see there is a good containment of the hematoma here, and there's a partial healing as well here. So we took the external fixator and we cleaned the inlets, and 2 weeks later, after we made sure all wounds are healed nicely, we took him for limb salvage surgery. We did an extensive resection of the tumor, but I remember around 30 to 32 centimeter resection, and the patient had an excellent life was alive for 5 years, walking, ambulating well, but eventually had a widespread bony and lung metastasis, and he died 5 years after surgery. Now, just to touch base on soft tissue tumors, we talked about benign and malignant soft tissue tumors. They usually presented the same as painless soft tissue tumors. But they're usually, the malignant soft tissue tumors become painful when they come in the big size or they compress important neurological structures. Always remember that the cutoff size is 5 centimeter. Any tumor that's more than 5 centimeter should raise a suspicion of malignancy, or a tumor which is deep to the fascia. But again, there is no laboratory test that tells you that this is a malignancy or not a malignancy. Imaging is the most important thing. You do an MRI, you look at the tumor, and it gives you a better delineation of the behavior, the nature, and the anatomy of that lesion. Sometimes we add also CT scan for detection of some soft tissue calcifications, especially in cases of synovial sarcoma or an osseous infiltration as well. This is a typical MRI of a patient who had an aggressive sarcoma. This is sarcoma in the back here. And if you look here, there is a lot of necrosis or breakdown in the symptoms. So this tumor is grown badly. So what do? We do again non-invasive biopsy. We take a true cut biopsy through ultrasound guided. But sometimes if the ultrasound guided fail, we do an open incisional biopsy. An open excisional biopsy, it's removal of the entire tumor as a biopsy. It's only permitted again in tumors less than 3 centimeter. And it has to be also taken by an orthopedic oncology. Even a tumor which is less than 3 centimeter can still have the chance of being malignant. So my advice, if you're taking a tumor which is less than 3 centimeter, try to take it also with even a soft tissue margin around it. I always put this slide in my presentations. This is Prof. Henry Mankin. He always tell us that you will never be blamed of doing a biopsy. And nobody will say, well, you're wrong, you did a biopsy and you treated these patients. And there are hundreds of biopsy, classic papers on biopsy that tells you the hazards of doing biopsy and the way to do the biopsy in the correct oncological manner. And then you come to the management, you treat these patients. Again, we talked about the preoperative radiotherapy in patients with soft tissue sarcoma, and then you do wide local resections. Again, we always discuss these cases in the multidisciplinary tumor board, and we get the consensus about the treatment immediately in the tumor board. And the oncological resections, again, follow the same principles like the bone resection. The standard of care is wide local resection. But amputation is always performed if it is difficult to achieve a negative margins in a high-grade sarcoma, and radical resection, you might sometimes do radical resection to take out the entire compartment. This is the NCCN guidelines that I talked about earlier. And if you look here, surgery followed by radiotherapy, or preoperative radiotherapy followed by surgery. Again, we always try to discuss these categories of treatment in the sarcoma part. It really gives me a bit of a freedom to decide which way to go. It's either to give surgery, to do surgery first and give the patient radiotherapy, or to do preoperative radiotherapy followed by surgery. It all depends on the soft tissue envelope around the tumor. If you have an excellent soft tissue envelope, then I always go for preoperative radiotherapy followed by surgery. Again, this is a 62 years old male patient, had a biopsy-proven synovial sarcoma involving the knee, tibia, as well as the patellar tendon. We opted to do preoperative radiation therapy and to do local resection, but I'll tell you why I'm putting this case. Honestly, if you look here, this is the tumor invading the patella, invading the tibia, tibial tuberosity here, as well as the lateral all the lateral structures, part of the femur here. So we opted to give him a preoperative radiotherapy, and you can see the soft tissue envelope with necrosis here, although we waited for 4 weeks here. The resection was really a huge resection. We took a hemicondylar resection of the tibia. We took everything out. We did knee arthrodesis here, and then we covered it by flaps. But retrospectively, I would probably choose to do for the patient surgery followed by radiotherapy. He eventually got a good healing right there, but unfortunately, he got a lung metastasis later on. So more than 5 centimeters, increasing in size, a mass deep to the fascia or pain, or if you have a recurrence of a previously excised lump. These are very factors as malignant. Again, I keep repeating this slide, you're wrong. So that's what we call the OPS procedure. OPS procedure, if you do an unplanned resection of a lump that tend to be sarcoma, and then you're surprised inside the surgery, you tell, oops, this is not a benign tumor, this is a sarcoma. So always get the original operation note, review the pathology, and MRI for minor resection. Again, there's another terminology which we call it OCULOBRACHAIL reflex. A surgeon who sees a mass and then book the patient to OR without even doing any investigations, surgery, and then when he gets the pathology, he was surprised that this is sarcoma, and then at that time he fires the referral. So what do we receive? We usually receive a badly placed incisions. Sarcoma diagnosis, patients most of the time they have a positive margin. If you look at the literature, it tells you around 2/3 of these patients, they have a positive margin even if the surgery was done by most experienced surgeons. That's why we justify always wide surgical resection of the tumor bed together with the flap and skin graft as well. But these patients, the literature has proven an incidence of increased metastasis and local recurrence together with overall survival. So again, we discussed these tumors. Our standard of care is tumor bed resection and soft tissue coverage and reconstruction. Post-operative radiotherapy is a must for all of these tumors. If you look at the NCCN guidelines, that's definitely proven by the NCCN guidelines. As an example of such a very small lesion here, which was 1 centimeter lesion over the anterior tibia. The lesion was taken out or excised by an general orthopedic surgeon. Unfortunately, it turned out to be a soft tissue leiomyosarcoma here, and then now the bone is contaminated, invaded. So we took that area out completely, and we took the bone hemicortectomy of the tibia, and we have to cover that area with the proper flap based on the dorsalis pedis artery from the back here. So in general, in summary, the sarcoma service is a multidisciplinary team management, and we do have advancing in imaging techniques and multi-modality treatment. It really made limb salvage and our job much more easier. Again, these cases has to be treated in a tertiary referral center, and it's always, you always think of a sarcoma as a surgical disease, and you have to have an early referral to sarcoma centers. And again, you always follow international guidelines for management of soft tissue sarcomas, and by the time when you get the experience, you will probably have your own guidelines in your center. With this, I conclude my presentation. And just to remind you that in July is the month of the sarcoma awareness, and we always try to make some kind of activities to increase the awareness of the general population as well as the orthopedic and general surgeons to the disease of sarcoma. Thank you so much.
Thank you, Dr. Ahmed, very much. Thank you for the informative presentation. Today, now we'll take the questions coming to us. I will start with the question from Dr. Damrouz Aman. He's asking about recent advance in giant cell tumor of bone.
Well, if you look at the literature, if you're talking about the advances in surgical management, you know, if you look at the literature, there is a very famous article in the University of Toronto. They compare the adjuvant treatment. This is one of the recent advances. People, they go always to the technology of treatment of these cases. The recent literature tells you probably cryotherapy is the best adjuvant treatment in giant cell tumor. But again, look back at the literature tells you the most important management in giant cell tumor, we're talking about surgery, is adequate curettage using high-speed burr. But if you're looking at the medical treatment of giant cell tumor, now the denosumab is approved a kind of modality of treatment of giant cell tumor. Now, most of the cases where you have a Campanacci grade 3 giant cell tumor, we always tend to give them denosumab treatment in 9 doses. And these patients, they get an excellent response to allow you for proper treatment. But again, technologies are evolving.
Okay, thank you, Dr. Ahmed. Next question, Dr. Kazi Shahadat, he has 2 questions. The newest treatment modulates of GCT and osteosarcoma.
Well, I can tell you about the surgical treatment. There is a lot of medical treatment out there here. We depend on the classical chemotherapy. If we talk about medical treatment, we depend on the classical chemotherapy or the MAP protocol for treatment. But there is now the 2nd generation sequences, which is evolving really in the world, and people now is using a targeted treatment against specific genes within the osteosarcoma. So the medical treatment is improving probably much more than the surgical treatment. In the surgical treatment, we still have the limb salvage surgery and the joint salvage surgery. So we're advancing in terms of technology rather than techniques.
Okay, next question from Dr. Kazi. He's asking about biopsy. Which type biopsy will be referred for confirmation of diagnosis?
So biopsy, if we talk about the bone biopsy, the standard is a core biopsy. For bony tumors, we take a core biopsy under CT guided. We always go for non-invasive biopsies before we go for open biopsies. Now, if the bone tumor has a soft tissue component, we take an ultrasound guided biopsy using, again, true cut biopsy from the soft tissue component, not going into the bone. While for soft tissue tumors, again, we use the ultrasound guided biopsy to take a core. Some centers, they take an FNA, but this really needs an experienced cytopathologist, and we don't usually recommend it. We always recommend a true cut biopsy.
Okay. This question from Dr. Ali Abdullah. Is lavage useful in treatment of sarcoma of jaw, like mandible sarcoma?
Lavage? What
Slavage,
kind of...
yes. Slavage.
Salvage and yeah.
Salvage, sorry. Okay.
Well, yeah. Well, when you talk about salvage, yes, we discussed so many cases of sarcoma because all of these sarcomas, they come to our sarcoma tumor board. So we've been in touch with the maxillofacial surgeons, and they do, yes, they do maxillary resections, they do mandibular resections. So say that they salvage and they cross the gap by using flaps and vascularized fibulas. Yes, it definitely is. It's a feasible option.
Okay, our last question from Dr. Ben Mahmoud, management of desmoid tumors.
This is one of the controversies, actually. This is one of the controversies in the literature, how to manage these desmoid tumors. Like back in my training, I used to follow the Birmingham protocol for management of these tumors. But if you go now to the recent literature, or whenever you go to any of these international conferences, people tend to get away from management. So they don't usually like to treat these tumors surgically because, you know, whatever you do, these tumors, they will come back again to the patient. So what we adopted right now, if the tumor is really close to an important neurovascular bundle, we go ahead for surgical treatment if we can do it easily. But if we cannot, we give the patient preoperative chemotherapy, and then we treat the patient, because you don't want this tumor to grow and to invade that neurovascular bundle. While if the tumor is away from the neurovascular bundle and you can easily assist it, I tend to leave that tumor with a frequent follow-up every 3 to 6 months. Because, you know, these tumors, they come back very quickly.
Okay, this is, okay, do you have a last question? For the pathological effects of the tumor with Ewing, did you have any Mary Bearer for application of effects? Thanks. Dr. Isgani Gari, again. For the pathologic effects of the tumor with Ewing's, did you have an Mary Bearer for application of effects?
Well, if I understand the question nicely, what are the how to apply the external fixator in the supraacetabular area? Well, this is a very tricky. Area. This was actually, to be honest with you, this is the first time I do supraacetabular external fixator, because we don't usually do it. Like if you have a femur neck fracture, we'd rather go do fixation and get over with it. But to do an external fixator in such a patient, you really have to know the anatomy. So you have to do an internal Judet view together with internal oblique views to get good view of the inside of the pelvis, because you know this. The supraacetabular area is really very thin. So if you error inside, you probably will injure the neurovascular bundle or injure the femoral nerve. So you would do multiple imaging during the surgery by doing Judet view and outlet views to better understand where is your medial wall of the acetabulum and the inside of the iliac bone.
Okay. Thank you, Dr. Ahmad, very much for the presentation. Thank you for the effort, for the time. It's a pleasure to have you today. Sure, thank you for all the attendees. After tomorrow, you will share the video of the presentation in our website and LinkedIn, Biotech Healthcare, to one who cannot attend today or maybe attend delay. Now we finished. Thank you very much for your time, Dr. Ahmad, again. Thank you for everyone. Thank you very much. Follow us in our LinkedIn. We will share with you our next webinar will be next week, inshallah. Thank you very much.
Thank you, Sam. Thank you, everybody.
Thank you, bye-bye.